CCHCSP webinar, and we're really excited to have Dr. Lisa Robinson talk to us today. So Lisa is a scientist, clinician scientist in the cell biology program. She's a pediatric nephrologist, excellent physician, excellent scientist, well-funded, and importantly for this presentation, she's the Chief Diversity Officer at the University of Toronto. And today we're going to have a session that Lisa's going to talk to us about addressing diversity and inclusion in academic medicine. And just to let people know, format-wise, we're going to have a break after Lisa presents data looking at diversity and equity in academic medicine. And so please type in your questions and we'll keep track of them. At that break, we'll answer questions relevant to that. And then Lisa's going to talk about strategies that U of T is implementing to try to address these issues. And then again, we'll have questions after that. So without further ado, I'm going to let Lisa talk to us about this very important issue.
Great. Well, good afternoon, everybody, and thank you, Nicola, for that very kind introduction. So as Nicola said, I'm going to try to talk a little bit about some of the issues that face all of us with respect to inclusion and diversity in academic medicine. So this is new, just a disclaimer, this webinar stuff is new technology to me, so you'll have to just kind of bear with me, but I'll do my best. There we go. So just in the way of objectives, what I thought I would start off by doing is maybe discuss some of the benefits of diversity in academic medicine, and then talk a little bit about the current landscape. So how are we doing so far? And then, as Nicola said, we'll take a break there, and then we'll get into some of the things that we're doing at the University of Toronto and the Faculty of Medicine, and our approach to trying to create diverse and inclusive teams, recognizing that we're very early on this journey and we have much more that we need to do. All right, so what I thought I would do is maybe start off a little bit just by going through some very basic definitions. And the definitions are really the definitions that come from the AAMC, so the Association of American Medical Colleges, and U of T actually belongs to the AAMC. So when we talk about diversity, diversity embodies inclusiveness, mutual respect, multiple perspectives, and it serves as a catalyst for change resulting in health equity. In this context, we're mindful of all aspects of human differences, such as socioeconomic status, race, ethnicity, language, nationality, sex, gender identity, sexual orientation, religion, geography, disability, and age. And just a few more definitions. And so again, this is also from the AAMC, but when we talk about inclusion, inclusion is a core element for successfully achieving diversity. So inclusion is achieved by nurturing the climate and culture of the institution through professional development, education, policy, and practice. So the objective here is to try to create a climate that fosters belonging, respect, and value for all, and to encourage engagement and connection throughout the institution and the community. So when we talk about the climate and the culture, so the culture really refers to deeply instilled values and beliefs of an institution. And the climate is about perceptions, attitudes, and behaviors that reflect the beliefs and values, so really the culture of an institution. So this is probably evident to everybody, but why is diversity important? I mean, what we believe strongly that an academic medical center should reflect the community in which it's housed. And we can really define that any way that we want to. It's sort of arbitrary. So when we talk about the community, is it our city? Is it our province or state? Or is it our country? And we know that diverse medical communities have a positive impact on the workforce. And diverse medical schools have a positive impact on education. And we'll get into this a little bit more. So there's lots of literature that tells us that having diverse medical classes or diverse physicians positively impacts patient care. So there are several studies that show that underrepresented minority faculty are more likely to work in underserved areas and to care for underrepresented minority patients. And not only that, minority patients tend to seek care from and to report greater satisfaction when they receive care from a minority physician. So what about medical school classes? Well, we know that having diverse medical school classes very positively impacts medical education. So there are positive effects on the curriculum. So not just the formal curriculum, but the informal curriculum, and very importantly, the hidden curriculum. And we know that having diverse classes has positive effects on learning outcomes in these medical classes. And the reason really, it's probably pretty obvious, but when you have diverse classes, it creates an environment in which cultural stereotypes and assumptions can be challenged. So it's good not just for the people who are underrepresented in classes, but it's good for the whole medical class. And what we know is that having diverse classes actually produces better doctors who are more culturally competent and can provide better care for patients, especially our diverse population of patients. So what about science? And so we also know that diversity positively impacts science. And there are several studies that show that when you have gender heterogeneous working groups, you actually write better papers. So you produce better papers that are cited more often and that actually have higher impact. And just to highlight a couple of other studies, we also know that when you have diverse teams performing science, this again leads to better papers that are more highly cited and in higher impact journals. And it kind of stands to reason, because when you have people with very different perspectives in different frames of reference and experiences, thinking about a problem from different perspectives, the net outcome is going to be better. So as many of you probably know, the NIH has actually identified this as a priority in that they appointed Hannah Valentine, who was formerly at Stanford, a cardiologist and scientist, as the Chief Officer for Scientific Workforce Diversity. And the NIH is now addressing issues of inclusion and diversity, and also the science of diversity. All right, so maybe just to sort of put things in perspective, and because I believe that our audience is Canadian and American, I'm going to show a little some American data and some Canadian data as well, and some Toronto data. So how are we doing? So this is just census data. So this is the US population, and this is by race and ethnicity in 2012. And if you look at the whole pie, what we see is that if you look at the US population, so about 63% of people are white, about 16.9% are Hispanic or Latino, about 13.1% are Black or African American, 1.2% are American Indian or Alaskan Native. Uh-oh, I lost my pointer here. There we go. And about 0.2% are Native Hawaiian or other Pacific Islander. So if you look at this combined population, so Hispanic, Latino, Black or African American, Native American, Alaskan Native, Native Hawaiian, Pacific Islander, this is about a third of the population, so 31.4%. So how are we doing in medicine? And so this, again, the data comes from the AAMC. So this is the AAMC facts and figures. This is from 2015. So if you look at US medical school graduates, so in 2015, if you look at the populations that we talked about before, so Hispanic or Latino, Black or African American, Native American, Alaskan Native, Native Hawaiian or Pacific Islander, 10.4%. So that's fully a third of what it should be. And it gets a little bit more grim too when you look at faculty. So again, this is the AAMC faculty roster. So this is as of December 31st, 2016. And what it shows us that if you look at the almost 67,000 faculty at US medical schools that of which 100,000 or so are men and about 66,000 or so are women. That if you look at the same groups that we talked about before, they're grossly underrepresented. So 5.8% of US medical school faculty belong to the groups that I mentioned before. So long way to go. All right, so what about Canada? So this is from the National Household Survey. So this is census data from 2011. And as we know, the population of Canada, so at this time was about 35 million or so. And if you look at the entire population of Canada, about 21% of people were born outside of Canada. And in the 5 years leading up to this, and in fact the trends have stayed the same, most immigrants came from Asia, including the Middle East, Africa, the Caribbean, and Central and South America. And if you look at the entire Canadian population, about 19.1% of the population belongs to what the government terms visible minority groups. So South Asian predominantly, Chinese, and Black. So that's, and together they comprise 61%. So across Canada, the Indigenous population is about 5.4%. All right, so what about Toronto? And so this is City of Toronto data from 2013. And at this time, the population within the city proper was about 2.79 million, and within the Greater Toronto area, about 5.5 million. So those of us who live here know that Toronto is an unbelievably multicultural city. So it's estimated that more than 140 languages and dialects are spoken here, and that more than 30% of residents speak a language other than our two official languages, which are English and French. And within Toronto itself, about half the population was born outside of Canada. And within Toronto itself, almost half the population, so 47%, report themselves as being part of a visible minority. And according to Statistics Canada, they define visible minority as persons other than Aboriginal peoples who are non-Caucasian in race or non-white in color. Now, if we look at Toronto, the top 5 visible minority groups are, so South Asians comprise about 12% of the population, Chinese, 11.4%, the Black population is about 8.4%, Filipino, 4.1%, and Latin American, 2.6%. Now, and City of Toronto data tells us that about 0.5% of the Toronto population is Indigenous, but it's thought that this is a gross underrepresentation of who is actually here. So now how are we doing it at U of T and in the Faculty of Medicine? So one of the, you'll remember that there are about, so if you look at female faculty, so that's about 65,000 or 66,000, and you'll recall that there were over 100,000 male faculty. So what was interesting is that about 39.6% overall of faculty members at US medical schools are identified as female. And of these, if you think about sort of climbing through the ranks, so when people are appointed, they may be appointed as instructor, and then as you climb through the ranks to assistant professor, associate professor, and then the highest rank, which is full professor, of the female faculty, about 12.5% of these faculty are full professors. And I'll just contrast that. So this is from the same survey. So again, a AAMC faculty roster. And of the 100,000 male faculty at US medical schools, so this is 60.4% of the faculty are male. And of them, so 27.8% of male faculty are full professors. So this is more than double the percentage of women faculty that are full professors. All right, so what about in our little corner of the world? So here at the University of Toronto, as a paper, which was published in the American Journal of Public Health in 2012. So this looked at promotion rates from assistant professor to associate professors, and these were faculty that were recruited in the years between 1983 and 2000. And what they found is that for white faculty members, 30% of them were promoted from assistant to associate professor. For Black faculty members, it was significantly lower at 21.7%. For Hispanic faculty members, it was 26.2%. So what about promotion from associate professor to full professor? So the same sort of, the same recruitment period, so 1983 to 2000. And what this study found is that when you looked at, so for white faculty members, so 31.6% of them were promoted from associate to full professor. And for Black faculty members, it was significantly lower at 19.8%. And for Hispanic faculty members, it was 27.3%. So there are many studies that show that, in fact, if you look at minority faculty, there is slower advancement. So both scholarly advancement and, importantly, professional advancement. Whoops. Uh-oh, what did I do? Sorry. And then also, this study demonstrated that if you look at underrepresented minority faculty, the promotion rate from associate professor or to associate professor lags behind the promotion rate for white faculty by 3 to 7 years, which is very significant. And I think part of the reason here is something that's called the cultural tax, and I know that many of you are familiar with this term, or the minority tax. And what this refers to is the idea that diverse faculty members are saddled with disproportionately a heavier load of committee work, teaching, and advising work. And this is especially in departments where that are not very diverse. And so if there's only one or a handful of somebody who identifies in one way, that person or that small group of people are called upon over and over and over to sit on every committee and to be the voice and the representative of whatever group they might identify with. So this is a major problem. And you can see that it's sort of like a self-fulfilling prophecy too, because it's incredibly important that when we have faculty who are underrepresented in any particular department, it's so important that they achieve and that they're there to do a job, and they need to be successful in that job so that they can serve as role models for those that come after them. And there are many studies that show that. If you see it, you can be it. So I'm just going to highlight some of the findings from these studies as well. I mean, there are other studies that show the same thing. So if you look at underrepresented minority faculty at academic institutions, they're much more likely to report feeling isolated, to feel excluded, invisible, and that there's poor fit with their institution. And underrepresented minority faculty are almost 4 times more likely to report dissatisfaction with diversity. And underrepresented minority faculty are 3 times less likely to believe that networking, and importantly, that's informal networking, includes minorities. And underrepresented minority faculty are significantly less likely to believe that they're actually going to remain at their current institution in 5 years. So how are we doing? And so I'm going to just sort of switch gears a little bit and highlight this paper, which was published in Academic Medicine last summer, so in August of 2016. So it's called Measuring Diversity of the National Institutes of Health Funded Workforce. And so they did an interesting thing. So what they did is they looked at NIH-funded awardees, and they compared them not to the general population, but to the relevant population of individuals who would be eligible for such an award, so the relevant workforce. So just as an example, so when they were looking at people with an advanced degree and employed as a biomedical researcher, so a professional with either an MD or equivalent or a PhD or equivalent, instead of comparing to the general population, they compared them to the relevant labor market or the relevant population. So this would be to a population with a bachelor's degree. So when they looked at people who were funded by the NIH, so whether it was NIH postdocs, so trainees or fellows, or NIH, people who had NIH independent mentored K awards, so career development awards, or NIH research project grants, so awardees of RPGs, or NIH R01 equivalent awards, just like we obviously have similar things in Canada through CIHR. Instead of comparing them to the general population, they compared them to the relevant labor market, so the population with an advanced degree, so professional or PhD, who is employed as a biomedical researcher in any industry. And they saw some really interesting trends, actually. And so I'm just going to get you to focus maybe here. So if you look at this is postdocs, and then we'll group these together. Maybe we'll group these. Well, then we'll look at the K awardees, and then we'll look at the awardees of project grants or R01 equivalents. And so when you looked at a white or Hispanic population, so they were fairly well represented, even at the postdoc level, and even sort of going on beyond that. If you looked at the Black population, so at the postdoc level, they were fairly represented, well represented, when you compare them, obviously not to the general population, but to the relative labor market. And then for K awards, they did reasonably well, but there's this precipitous drop-off after that when it came time to securing awards that come after a career development award. And when you look at the Hispanic or Latino population, again, like there's a little bit of, with respect to postdocs for males, there's a bit of room for improvement. The female trainees did pretty well. And again, even though for K awardees, the success rate was pretty high, it stayed not too bad for males, but for Hispanic women, there was this precipitous decline. And I'm going to highlight here the Asian non-Hispanic population, and what they found is that they were vastly underrepresented when you compare them to the relevant labor market for postdocs, as well as for everything that came afterwards, so securing independent awards. But what was really interesting is that that difference disappeared when they looked at citizens versus non-citizens. So citizens did pretty well, non-citizens not nearly so well. All right, so again, on the theme of how are we doing, and I'm going to highlight this study. This again came out in Academic Medicine, and it was published in August of 2016. It's a longitudinal analysis of gender differences in academic productivity among medical faculty across 24 medical schools in the United States. And so this is the National Faculty Survey, and it was initiated with medical faculty from 24 medical schools. So it was initiated in 1995. And the aim of the study was to examine gender, racial, and ethnic disparities in productivity, advancement, and promotion. And they tried to focus on the bigger schools, and so they in particular looked at schools with at least 200 faculty, of which at least 50 were women and at least 10 minority faculty. And then interestingly, they went back and then surveyed the same faculty in 2012 and 2013. And what they found, they looked at like 1,244 academic medicine faculty, and then they looked at differences between men and women. And I just sort of highlighted in red what some of the significant differences were. And when they looked at the number of professors, there was a significant difference. So there were more male professors than there were women professors. And when so there was a significant, although I'm not sure, significant difference between the number of years since initial academic appointment. So it was 29.4 versus 28.2. And interestingly, when they looked at the marital status, the men were much more likely to be married or partnered, so 88 versus 73% of the women, and the men were much more likely to be parents than the women were. So this was 84% versus 69%. And when they looked at the teaching that was done, so the time for teaching, it was the women who had disproportionately more teaching responsibilities than the men did. So they then went on to look at publications. They looked at women versus men. And they again saw that there was some very significant differences. So when you looked at total publications, the men had significantly more publications than the women did. And then when they looked at publications in this period of study, so 1995 to 2012, again, the men had significantly more publications than the women, so 34 versus 25. And then when they looked at the H index, the men had a higher H index than the women, so 20 versus 17. And what was interesting, and I think quite sad, is that when they redid the analysis, the differences in publication numbers and H index disappeared for women who had no children. So one of the things in my role that I've heard on occasion, even from department chairs, is things like, well, the women in my department seem not to want to get promoted in the same way that the men do. So why don't we take a look at that? And this is another paper that was published in Academic Medicine in August of 2016. And it's a mixed methods investigation of the motivations, goals, and aspirations of male and female academic medical faculty. So between 2010 and 2011, so they did interviews with 100 former recipients of NIH Career Development Awards, and then interviews of 28 mentors. And what they did is they compared the survey responses of 1,267 award recipients, so these are clinician investigators in this period here. And what they found is that, so the women are here in light gray and the men in darker gray. And what they found is that when it came to, aspiring to publish high quality research, the women and the men actually had the same aspirations. When it came to wanting to publish prolifically, again, same, no difference. When it came to aspiring to provide excellent patient care, no differences between men and women. And when it came to wanting to teach the next generation, again, no differences between the men and women. So where they did see differences are when they looked at interest in attaining national or an international reputation as an expert. And the men were more interested in that, significantly more interested in that than the women were. And when it came to obtaining leadership positions, so department, school, or national leadership positions, again, the men were slightly more interested in that than the women were. And when it came to earning a high salary, the men were thinking more about this than the women were. And in contrast, when it came to wanting to find a way to balance work and other activities, the women were significantly more interested in this than the men were. So in just following up on that issue of high salaries, so this paper was published in JAMA in 2012, so the Journal of the American Medical Association. And it looks at gender differences in the salaries of physician researchers. And what they did is they looked at 1,853 recipients of NIH Career Development Awards, so these are K08 and K23 awards, that were awarded between 2000 and 2003. And then what they did is they followed up with 800 physicians who continued to practice in US academic institutions and who reported their current salaries. And what you'll see is that among these former recipients of these NIH K awards, the average salary for the women, so was about $168,000, whereas for the men, it was just over $200,000. So I think that's extremely telling. All right, so does gender have any influence when it comes to how grants are scored? And I'm just going to highlight this paper that was also published in that same issue. As you can probably guess, this whole issue of academic medicine was devoted to issues of equity, inclusion, and diversity. And so this one is an analysis of NIH R01 application critiques, impact, and criteria scores. Does the sex of the principal investigator make a difference? So what they did is they focused on grants that came from the University of Wisconsin-Madison, so in these years here. And they looked at the success rates for male and female investigators of type 1 grants. So type 1 grants are new grants, or type 2, so these are R01 or R01 equivalent grants. So type 1 are new grants, and type 2 are renewals. And what they found is, and again, the women are in the lighter color here, and the men are in the darker gray. And what they found is that when they looked at the new grants, well, everybody had a hard time, it looks like that. But when it came to looking at the rate of renewal, there was a significant difference between the men and the women. And in fact, the men were much more likely to get, significantly more likely to have their grants renewed than the women. So they also looked at priority scores, approach scores, and significance scores. And so what they found in here, so this is the priority score, and 10 is the best, and 90 is the worst. And what they found is that, so I'm not going to focus on the type 1 grants, because again, everybody had a hard time there, but on the renewals, what they found is that when it came to priority scores, approach scores, and significance scores, the men that were scored more highly rated than the women were. But this was in contrast. So they went back and then they looked at all the grants and they went and looked at the language that was used in the reviews. And so they looked at the words that were used to describe the ability of the investigators and standout adjectives, so things like outstanding, so things that really speak to somebody's proficiency. And what they found is that despite the fact, again, I'm going to ignore the type 1 grants, but for the renewals, despite the fact that the men were significantly more likely to get the renewals than the women were, when it came to all of the standout adjectives and the language around ability, the women actually did much better than the men did. So there seems to be some disconnect between the language in the reviews and then the outcome of the reviews. So maybe this would be a good time to take a break. So that's sort of like a bit of a background. And then so we can take some questions. And then maybe what I'll do after that is I'd like to sort of outline what our approach has been to date at the University of Toronto and the Faculty of Medicine.
Perfect. So please text in your questions if you've got questions. And while we're just waiting for people to type in questions, maybe I'll ask a few questions based on what you talked about. So one of the things that you mentioned was the hidden curriculum. And what do you mean by the hidden curriculum?
Yeah, so I mean, so the formal curriculum is all the stuff that we learn, right? All the textbook type of stuff. And the hidden curriculum is more, it refers more to the cultural aspect. So it's all of those things that they're not in the textbook, but it's all of those things that we learn about what's appropriate and what's not appropriate.
Okay.
Just from, dynamics and how things are playing out in the classroom or in the clinical context, but not the stuff that's written down, just sort of the way things are done.
Okay, I gotcha. Okay. And I was interested in the issue of publications and how taking into account whether or not you have children would balance out the differences between men and women for publication numbers. And is there a way, I mean, I'm assuming also that women that have children have taken maternity leave. And although I guess in the US there really isn't any maternity leave, so it probably doesn't make a difference. But in Canada, perhaps it makes a difference. And I guess, is there any way to sort of look at that? So let's say you took out the maternity leave time and shortened then the length of time that person had been able to be productive. Does that balance it out? Or is it something that continues on despite maternity leaves?
Yeah, that's a good question. I think, in Canada, I think the answer is that I'm not sure that we have the answer. We don't have the data, I think, to support that. But as you well know, I mean, grant panels are mandated to think about leaves or like that, and in periods where people are not at their most productive, and to be mindful of that and recognize that life happens and there are going to be differences. And so we need that data. We don't have that data, but I think we also also have to think a little bit more broadly, because it's not just the maternity leave, but it's everything that happens afterwards. And certainly, you know, there is other data suggesting that, especially with young families, so the work may disproportionately fall to women or to mothers versus fathers. You know, that might be changing now, but certainly that's kind of the landscape. So I think it's fine to focus just on the maternity leave part, but I think we need to think a little bit more beyond that as well.
Okay, and I guess similar to sort of following along this, a question here is comparing Quebec. And so Quebec in the FRQS has changed the scoring years of experience accounting for pregnancy leaves. And that seemed to have made a difference with grant success. And the question is, are there any publications that compare Quebec with the rest of Canada?
Yeah, that's a great question, and I'm aware of that, what has been done in Quebec. I think that's a model that we should all be looking to. I'm not aware of any publications. That doesn't mean they exist, but I haven't seen that published. I just know about that sort of anecdotally, but I'd love to see that data as well.
Right, and then I guess another question to follow up on that is, what about the composition of grant panels? So there's some interesting data that shows, at least for meetings, the planning committee, if the planning committee has more diversity, then the invited speakers have more diversity as well. Yeah. And so do we know anything about the composition of grant panels, for example, at CIHR or the NIH, to address, you know, why is this sort of disconnect between this, you know, the scores that people actually get based on gender, for example?
Yeah, but I think that's an incredibly important question, and actually I'm going to talk a little bit more later on, not in the context of grant panels, but I think it applies to everything around bias, implicit bias, and what happens when you have committees, et cetera, that are more diverse. I don't know about but I'd love to see that data. I suspect it probably makes a huge difference who sits on the grant panels, not just with respect to sex and gender, but, you know, with respect to other aspects of diversity as well. But I haven't seen that published, but I bet you that makes a difference. And when I talk a little bit more about what we're doing at U of T, I think that's such an important principle, and that needs to be applied throughout. But thank you for raising that.
So I guess probably we might all be thinking this question, having seen the data and how pervasive, you know, the facts are. Why does it seem to be that there isn't recognition that this is a problem, for example? Why is it so hard to get people in leadership roles to be aware of these issues, even still today?
Well, that, again, thank you. That's a great question. I ask myself that question every single day. And I think, just to use U of T as an example, I mean, we have a leadership team, and we have a dean who's made this a priority and says this is important. And that sets a tone for the whole faculty now. I think, just speaking from the Canadian perspective, I think one of the reasons why this has been an issue is because we have not collected these types of data systematically the way that we should. And so, you know, the data, and I'm going to talk a little bit more about some of the data we have collected at U of T going forward. And let's be honest, the data make people uncomfortable. People are uncomfortable when they see these things. And because we all want to think that there's not a problem, that there aren't any differences that exist, and that there's not bias. But it's only when you have the data in front of you, which we're now starting to collect in Canada, that you can actually, it's compelling. That's sort of the call to action. I think if we don't have the data, and we have not had the data that we need in Canada, it's easy to say, oh, there's not really a problem here. But when it's in front of you, then you have to do something about it. I think one of the other reasons is that you know, leadership is not, the leadership, I think, at academic medical institutions is not particularly diverse either. And I'm going to, I'm going to get a little bit more as I'll present some information about that and what we know about that. But at the leadership level, we're not that diverse actually at academic medical institutions, and that makes a difference. So if we can start, so we need to do better, I think, in terms of having more representation, all aspects of diversity and inclusion, so recruitment, retention, but very importantly, leadership opportunities. Because when the leadership starts to reflect our population better, then more of these issues become top of mind. But I think that's so important.
Okay. I was interested in the data that was looking at women's desire to sort of have leadership roles, or, and I guess my question is, if you dig down, what's the underlying reason for that? Is it because there's no, if you see it, you can be it? Or do you think there's some other underlying reasons why women didn't have the same desire as men to have leadership positions?
I for sure think there's part of the if you see it, you can be it. So I definitely think that's part of it. And there's lots of data and lots of information around that, for students and for young faculty members. If you don't see role models with whom you can identify, whatever, in whatever way that's important, then you're much less likely to think that you can actually attain that too. So I think that's part of it. And there are other studies that show that women are not as, I'm not going to say self-promoting because that's negative, but they don't promote themselves as well as men tend to. And so when it comes to things like negotiating, around recruitment packages, negotiating startup packages, women are not necessarily as good advocates for themselves as men tend to be, and there is information around that. So, I like the origins of that, I think we can sort of look way back down to preschool and before probably. We know that starts very early, but we need to be mindful of that.
Mm-hmm. So I guess looking at the grant funding rates was interesting. Is there similar data looking at, let's say, the diversity of applicants for medical school, for example, and then those that actually get accepted into the program?
Yes, that's great. That's an excellent question. And this is something that I have I've talked about this all the time here in Canada, because we have data, and I'll just focus on our medical school and our medical students. So we now have data for the last few years about our medical students, so who's accepted to medical school, but it's irrelevant if we don't know who's applying to medical school. So a few years ago, it's not published yet, but there was a survey that was done that went out to medical school applicants. So this is at 3 Canadian medical.
Someone has asked about the CIHR funding and the data that was released this summer that showed that actually gender discrepancy in funding has gotten worse since the introduction of the CIHR reforms, not better. So any idea why that has happened?
And thank you for bringing that up. I don't know why that's happened. I don't have any ideas around that. But again, that should be extremely concerning to all of us in the biomedical research community. And you probably also, and just sort of along those lines too, because it's been the headlines of every paper, even something like the CRC, so the Canada Research Chairs. And so the government is forcing every university and academic institution to take a good hard look at who they're awarding those CRC, those Canada Research Chairs to. And so the intention was again, in people's minds, there's always this, you can either have excellence or you can have diversity, without understanding that they go hand in hand, and you can only be more excellent when you're more inclusive and diverse. And so the intention was that CRCs, would be awarded to diverse recipients, including, women, Indigenous faculty, what they term to be visible minority faculty, and persons with disabilities. And as everybody knows, every institution has fallen very short in that regard, and they have not been allocated the way that they should be. And so every institution, including our own, is having to look at that and having to report back to the government about what they're doing to address this. And the government is, and the idea is that if institutions are not doing enough to address some of the inequities, they'll withhold funding. So, it's sort of like a carrot and a stick approach. Well, in that case, a stick approach maybe. But yeah, great question. I wish I knew the answer to that. I don't, but it's very concerning.
Okay, I think that's most of the questions that we have. Oh, hold on a second. Let me just see. Okay. Okay, so can you speculate on the root causes for the discrepancies in gender racial disparities in science?
Oh. Well, I know you're going to have a Twitter chat later on with Imogen Co. And Imogen has lots of ideas about this, which, and I think she's right on the money. It starts so early. I think it starts very, very early in terms of like even at the sort of like pre-elementary school and before, just in terms of role models and modeling. So seeing people who are like you, if you belong to one of these equity speaking groups, who do these things, who do science and who do biomedical research and academic medicine. And when you don't have these kinds of role models, it's hard, and especially if you couple that with economic disparities, it's hard to imagine that you can do that. So I think people start off in very different places. And our system, I don't think it has been, we know, all of our institutions are, they're quite conservative. They've been around for a long time. Things have been a certain way for a long time, and it change is hard. It takes a really long time. And I also think that change doesn't come easy because many people are advantaged by the current systems, and they don't necessarily want to give up what they have. So I think it's going to be, it's a long road, but I think what we need to do is start talking about it openly, and I am a firm believer that we need data. We need to be armed with our own data so that we can figure out how to think about these and how to address some of these issues.
Okay, so I have a devil's advocate question here, and it's hard to even imagine this would happen based on the data that you're presenting, but how would you ensure that the pendulum doesn't swing too far the other way?
Well, I'll start off by saying I would love to be confronted with that problem. I'd love to be confronted with that problem. And, maybe what I'll do is, in a minute, I'm going to talk about an approach that we're taking at U of T with respect, in the Faculty of Medicine, with respect to our medical school application program. And, I'm not saying that this, and so maybe I'll get back to you on that one, because we have different pathways through which people can apply to medical school. And so we have one that's, for want of a better word, I'll call it the generic program. And then for the last few years, we've had an application pathway for Indigenous students, so the Indigenous Student Application Program. And we've just launched a similar program for Black students. And intentionally, we've modeled those after the MD-PhD program, very intentionally here at U of T. And our approach has been that we have not changed the academic criteria at all. And so, in fact, the academic criteria in terms of GPA, MCAT scores, and all of that sort of stuff are exactly the same. But the only thing that's different is that applicants, and so it's obviously voluntary, people don't have to apply through these different pathways, it's voluntary. But the only things that are different are that applicants, in addition to the usual essays that they write another short essay about why they want to apply through this pathway, just like for the MD-PhD students. And I sat on the committee for years, the admissions committee. The students will write about their research experiences and what motivates them to want to be like an MD-PhD, a clinician scientist. So they'll write about that. And the other thing that's different is that for these other pathways, so for the MD-PhD application program, for example, and for the Indigenous Student Application Program, we make sure that there are there are members of the community, that particular community, that is part of the evaluation process, so part of the file review and part of the interviews. So for example, for the MD-PhD applicants, the people who are doing the file review and the interviews, so among them are clinician scientists and scientists. And the same is true. So for people, members of the Indigenous community are part of the Indigenous Student Application Program, like file review and interview committee. So we're doing exactly the same thing for this new program called the Black Student Application Program. And I will just say that just by talking, we just put it in place now. So it's just gone live now, and it will apply to people who are accepted into the class of starting in 2018. We've done nothing different yet, other than just talk about it and talk about why we want these students in our faculty and how they matter and they deserve to be here. And just by talking about it, and just through community consultation, we've been able to engage many more members of the Black community. So this is through the professional community and otherwise, to be part of the file review and the applicant review. And we've had many applicants through this pathway. So, and we've done nothing different other than say, you belong here. Because it only makes sense that we have, I think our ultimate goal will be to have panels that actually reflect our community. So that's a very long-winded way of saying that I don't think we're going to encounter that problem for a very long time. And our approach, at least with respect to this program that I'm talking about, intentionally has been to not change the academic criteria. And part of that is because we don't need to. There are lots of qualified applicants out there. And then also we know that when those applicants, because it happens now, I mean, I graduated from the Faculty of Medicine here in 1991. And I remember during orientation week, as happens every year, I'm sure, to the Black students, people coming, a couple of students coming up to me and saying, oh, I'm sure you got in through a specialized pathway. They must have made it easier for you to get in without knowing a thing about me. So we know that that happens. We know that students, when they're here, when they belong to underrepresented groups, that they already experience discrimination and some isolation. So we want to build a community of support here. Yeah. Oh yeah. So what I thought I would do now is, now that we've talked a little bit about the data, and thank you for those excellent questions, by the way, is to talk about what we've been doing here in the Faculty of Medicine and what we've identified as some of our strategic priorities. So again, I think one of the questions alluded to or addressed the fact that at the leadership really matters. And I think, if the leadership does not identify that this is an important priority, then it's very hard to affect change. So we actually have that, and we have a dean and a leadership team that really, really, really thinks this is important. So this is Dean Trevor Young. And, so a way to signal that was the appointment, he created this position, which I actually hold, the Chief Diversity Officer, in January of 2016. So this is the first time that our medical school has ever had a position like this. We've clearly needed it for decades, but first time. And then I was able to hire this incredible diversity strategist, so Anita Balakrishna, who started in January 2017. And Anita brings a wealth of experience to us. She's actually a lawyer by background, and she's a human rights lawyer, but she's worked in academia, she's worked in the community, and she brings an incredibly insightful lens, I would say, to these issues. And the first thing that we've done, I didn't put it here, is that we appointed a diversity advisory council. And so there are many people across the faculty, and across the Faculty of Medicine and at the University of Toronto, who are doing really important work in this space. In different areas, and this council is fantastic because we can get together and we can share ideas, best practices, and figure out approaches to all of the different things that we want to address. Because there's no need to, why reinvent the wheel? And some units are doing fantastic work and have really, really good approaches that we can all learn from and share resources. So what we've identified, and I think I've said this several times already, is that we think it's incredibly important to understand our environment. So that's where the data piece comes in. And so the few surveys that were done before really focused more on the demographic information. So with this fantastic team, so this is the policy and analysis team, and the survey, so the spearhead here is Glenys Babcock, who I'm so excited is going to be working with us more full-time to work on these other surveys, together with Mariella Rattelot and Carolyn Abrahams. And the focus of the survey, so we've redesigned them to capture much more detailed demographic information about our students. We focused on the medical students and on the residents and fellows, so the post-MD trainees so far. And more importantly, so not surprisingly, what we have found is that when we look at the demographic information, when you look at our U of T medical students and you look at the residents, all of the groups that I talked about before are very underrepresented. And very importantly, students who are actually our students and our residents and fellows are quite affluent overall as well. So there's overrepresentation for people who are in the most economically advantaged groups. So not only have we collected very detailed sort of demographic information, but we've designed this study so that we can try to really understand the culture. So what is the experience of the people who are here? So we've asked a lot of questions about discrimination, harassment, and not only that, many questions about sense of belonging. So do you actually feel like you belong here? And inclusion or exclusion from informal networks. And what we have found is that, when we look at, so in fact, a high percentage of students have experienced, or this is residents have experienced harassment and or discrimination on more than one occasion. And not only that, when you look at those experiences, as well as the feeling of being excluded from informal networks, it falls out very strikingly along racial and religious lines. And in fact, if you look at the people who seem to be targeted over and over and over, so there are differences along racial and religious lines, but in each category, the women suffer more than the men do. So the women seem to be the targets of discrimination, harassment in each subcategory more than the others. And so, one of the things we've asked a lot of questions. So we've been trying to understand, who is responsible for the harassment and discrimination? Because one of the things that, we've heard I've heard anecdotally is, this is happening in the hospital. So, it's patients, it's families. We can't really do much about that. And yeah, patients and families are number one, but a very close second is faculty physicians. And a very close third is allied health and nurses and other allied health. So it's us. It's not, patients and families, it is us. And so it's our collective responsibility to do something about this. And so when we take this data back and we report it to the leaders, this is so you have to respond to it. So I feel incredibly strongly that this needs to be a focus. So as I've said, so far we have focused on medical students and on the residents, so the post-MD trainees. But, so as I mentioned, Glennis is going to be working with us now on a full-time basis. And we feel that it's important to obtain similar information for everybody within our Faculty of Medicine community. And so we're going to be collecting similar information from our faculty and our professional staff, who I think have been neglected, but they make the whole place run. And very neglected, I think, so far, have been our scientific trainees and faculty. And so in the spring, we're going to be launching similar surveys, but they, of course, altered so that they make sense in the context for graduate students, for postdoctoral fellows, and we're also going to be surveying our scientific staff. So, once we gather this information, and I think we had a little bit of information before, but our tendency is to kind of keep things quiet, I think. I think that's exactly the last thing, that's the opposite of what we should be doing. And so we've purposefully tried to share the information that we gather with our stakeholders. And so far, some of the Voice of the Resident survey that I was just describing, we have presented the information to PAYRO, so the Professional Association of Residents of Ontario. We've presented it to the vice chairs of education for all of the departments that are in the Faculty of Medicine. And very importantly, we've presented it on several occasions to the leaders of the hospitals. So the Toronto Academic Health Sciences Network, or TASN, because this is happening in the hospitals. And so we've presented it, we've spoken to the TASN CEOs and to the leaders with respect to education and research, because it is our collective responsibility to try to change this. And it's not an attack on, your hospital's terrible or your hospital's terrible. It's our responsibility to try to change the culture and the environment, and we need to do this together. And I think this was a really important step because we need the endorsement and the buy-in from these leaders to be able to actually survey all and speak to all of the people that we want to, and we have that now. So I think that's really important. So, the second thing that we've been, more along the theme of trying to understand our environment, the follow-up piece is really important. And so when we surveyed, we sent the survey to the residents out now twice, and we have welcomed their commentary. So there's space for them to tell us, what do you think we should do about this, and what should be our approach? And we've listened to them, very insightful. And so one of the things that's come through loud and clear is that they want to know what to do. And so it's not clear to them, like if they experience harassment or discrimination, or they see it, what do they do about it? Who can they talk to, and how do they follow up? And so one of the things that we're doing is putting together, is just making very clear the resources and on our website and in other types of forum about reporting. Although, just sort of on this point, one of the things that was interesting is that when we surveyed the resident, one of the questions we asked them was, if your program, do you think your program would do something about this if they knew about it? And most of them said yes. But very, very few of them actually reported it. So there's a big disconnect, and obviously there's many reasons between why that disconnect might exist. It's fear. It's fear of reprisal, really. So the other thing that we've been working on is trying to create a response toolkit, and we're doing this together with the Office of Resident Wellness. Because, I didn't mention it, but we've also looked in this survey at wellness and resident wellness. And the wellness, actually, not surprisingly, there's a correlation with experiences of discrimination and harassment. And so what we're putting together is a response toolkit. So if this happens to you, or if you see it happening to others, somebody around you, what do you do about that? And so we're putting together some resources and material, even for faculty members, for preceptors, because they don't know what to do either. It's hard. So one of the things that we created is something called the Diversity Dialogue, and these are really just sort of like an open forum just for people to get together to talk about some of the issues. And in response to our first resident survey, we several months ago we held this session, which was called Let's Talk Islamophobia, and it was amazing because we had medical students, residents, faculty members, and just others from the Faculty of Medicine community and leaders from the Faculty of Medicine, just sharing stories and just sharing, approaches that they've taken. And it was such a powerful event. The other thing, so the next diversity dialogue is actually next week. So it's next Monday, October 30th. And this one is called How to Become an Ally. And so it's designed to, and we've worked very closely and with the team from Mount Sinai Hospital, because in the Toronto area, I think they are leaders. So how do you be an ally to racialized people, or to people who are LGBTQ or 2S? Or when you see this stuff happening, what can you do? Or when you witness it, what can you do? What can you say? And so this is happening next week. And it's going to be very practical. So with some really practical language about what you might do and how you might intervene. And sometimes it's not that. And this, we've all heard about this. So in the news, we've heard lots of instances, unfortunately, about physicians who have to deal with racist patients, etc. And sadly, I guess, the New England Journal of Medicine actually published a paper last year with guidelines about how physicians and institutions should handle racist patients, with like a checklist of things that you need to do. It's kind of sad that we need that, but so be it. And so this is happening next week. And sometimes being an ally doesn't mean that you have to do something in the moment, but sometimes it means taking the person aside afterwards, the person who was the target of some of this abuse, and acknowledging them and acknowledging what that must have been like, and being an ally for them. And that goes a long way. And our medical students tell us that. When it's ignored, just by everybody, let's just pretend that didn't happen. It's like double injury. And so, again, we focused early on, we focused so far on the clinical trainees, but we are very mindful of the fact that we need to develop these kinds of resources and reach out to our research, folks who work in our research environment. So trainees, staff, and faculty. And this is our next order of business. So again, I'm going to throw in a little bit more data, and I want to highlight this paper that was published by Sharon Strauss, who is phenomenal. So Sharon is she's a geriatrician. She is a clinician scientist at St. Michael's Hospital, and she's also the vice chair of Diversity, Equity, and Mentorship for the Department of Medicine at U of T, which is the largest department in the Faculty of Medicine. And so Sharon and her team published this paper in the Canadian Medical Association journal Open, so CMAJ Open, this year. And it's called Perceptions and Experiences of a Gender Gap in a Canadian Research Institute and Potential Strategies to Mitigate This Gap, a sequential mixed method study. So this is St. Michael's Hospital. We're going to call out St. Mike's, but this is St. Michael's Hospital here in Toronto. And basically, so in this figure, they looked at the percentage of male and female scientists that were hired from between 1999 and 2014. So the male scientists are in blue and the female scientists are in green, and I think this tells a pretty good story there. So the vast majority of the scientists who were hired were male, and I think as the data came to light, I think this has been a platform for St. Mike's to make more of an effort perhaps to for there to be a little bit more equity, and so things are starting to change towards here. And what's interesting, so this is very busy, so I'm just going to focus on a few different things. So in this particular study, Sharon's study, when she looked at the percentage of female scientists versus male scientists, so when she looked at the full-time scientists, so whether they be clinician scientists or employed scientists or associate scientists, so overall, again, not surprisingly, so far fewer of them were female, so between 23% to 39%, with the remainder being male. And the difference was extremely pronounced when you looked at basic scientists. Sorry, didn't mean to do that. But when you looked at basic scientists, so between, for these different categories, clinician scientists, employee scientists, etc. So between 0 and 11.8% of scientists were women. So the vast majority of the basic scientists were men. And among clinician scientists, in fact, when you looked at those hires, there were no women. So the other thing that she looked at in her study was rank. And so she looked at academic rank, so associate professor and full professor. And probably not surprisingly, like in many other studies, there were big differences between women and men with respect to academic rank. So far fewer of the women attained the higher academic ranks than the men did. So if you looked at like the full, so 90% of the full professors were men in some domains. But I think one of the really powerful things in this study was that it wasn't just sort of a data, it was an important analysis of data, but the qualitative data and the commentary was really important too. So They also interviewed 21 interviewees. And so among the interviewees, so 11 were identified as female and 10 as male. 13 of them were clinician scientists and 8 were employee scientists. And they looked at all stages. So, you know, a third of them were early career, a third were mid-career, 5 to 10 years, and a third of them were late career, so greater than 10 years. And they also looked at 4 former St. Mike's scientists. And I think some of the, you know, a lot of it comes back to what we were talking about around informal networks. And I'll just read this one. So this is one comment. So like this person, if I was female, would never have invited me out for a beer. It's that level of informal advancement that thankfully these kinds of things are pointed out by my partner who educates me on them, because it's not really something that I've been thinking about. But that's seriously problematic. It's nobody's fault, right? I mean, no one's trying to exclude based on gender, but it doesn't necessarily feel like you're excluding based on gender if you're extending invitations to meet informally with people. So we hear this all the time. It's that informal networking, and this is sort of a call to action for institutions to think about, and for, you know, for other, like at scientific meetings and other larger organizations, to think about how do we do this better. So the other thing, again, not as surprising, so another theme was trade-offs between career and family. So everything related to whether you're going to be an academic scientist or not is decided during your training. And if you have family and your training is delayed, if you can't work that much, then your publication list is not that good. To be that excellent, you're right away in a disadvantage. And that can happen more often to women and to men. And we saw that in that previous study that I highlighted to you. So we need to be more mindful about this as well. And then the third theme, and we'll get back to that later on, and we talked a little bit about bias and transparency. So it was around the transparent recruitment process. I don't think that this can be addressed until we're going to have recruitment which is more open, with candidates applying for these jobs from all over. And then we can see whether this gender gap is still there, whether there's a gap among applicants, and whether there is a gap after the selection process. And so transparency. And so, you know, she's been able to use this to lead change at her own institution. All right, so back to some of the priorities that we have in the Faculty of Medicine. So the second one is really about sort of that pathway. So recruitment, retention, promotion, and very importantly, leadership opportunities for people who have diverse backgrounds and experiences. And it starts off really early. So some of you may be aware that we have, for more than 20 years actually, we've had a program at U of T in the Faculty of Medicine called the Summer Mentorship Program, which is for high school students. And this is specifically for underrepresented minority high school students, so Indigenous students, Black students, and economically disadvantaged students. It's a 4-week program where they're exposed to all sorts of different careers in the health professions, and in health-related science as well. And then recognizing that there is a gap, and so, you know, there are other programs, and we have one, in fact, here at SickKids, which provides paid research opportunities, and I'm smiling at people in the room because they've been amazing mentors for these students, for high school students who are underrepresented minority. But so there are some programs that exist for high school students, but we recognized a few years ago that there's a huge gap when it comes to undergraduate students. So Ike Okafor, who works in the Office of Health Professions Student Affairs here in the Faculty of Medicine, in 2015, March 2015, created this program called the Community of Support. And this is specifically for undergraduate students, underrepresented minority undergraduate students who are interested in careers in medicine. And the program just provides mentorship for them, because that's the thing that current medical students have. And so that's the thing that these students don't have that current medical students have. And so I told you before that when we look at our own medical students, they tend to be affluent. And I can't remember the exact number, but it was about 20% of them have at least one parent who's a physician. So they have connections and they know how to sort of get in there and they know what they need to do. But that's the thing that many of these students are lacking. So as part of this program, the Community of Support program, the students are paired with medical school mentors and faculty mentors as well, who can provide them with, sometimes with shadowing opportunities, with research opportunities, the opportunity to get involved in small projects. And the medical student mentors help them with their applications. They can help them, read through their applications and look at them. We actually partner with a professor in the Department of Caribbean Studies who teaches the students about how do you write a personal statement. So what are the elements of a good personal statement? And they've had, and then there's another program which is a biostats course, which is put on by a phenomenal Rhodes Scholar internal medicine resident here in the Faculty of Medicine to teach them about biostats, and on occasion they have the opportunity to publish the research that they do with him. So a group of students actually published a paper in JAMA Cardiology not long ago. And so one of the things that we're working on is trying to figure out how to provide more research opportunities. And what we are trying to do now is to partner with MD PhD students and then hopefully eventually to trainees in the clinician investigator program who can act as mentors for some of these students to try to help get them involved in research and other opportunities that are going to strengthen their applications. The medical students also do practice interviews for the medical students. And in fact, so this program, as I said, was started in 2015, and it started off being a local thing. So now it extends just to undergraduate students across the country. And I think there are over 700 undergraduate students who belong to this. And it actually works. And so, when we look at the students who applied to medical school last year, a pretty big number of them actually got accepted to Canadian and US medical students. So it's all about just the mentorship and having people to give you a hand. So the other thing that Ike Okafor, who created this program, did is, recognizing that so mentorship is important, but money is important too. And so another barrier to many of the students is the MCAT. I mean, that's the bane of many people's existence. And so the MCAT, it's expensive. And so we did a little study at U of T looking at our medical students, and the MCAT, so it's not just the cost of writing the test, that's a few $100s, but it's everything around it. So doing these courses that people do, or getting the materials like the booklets, or just not even working as much in the months leading up to it. So it's not just a few $100s for the test, which in of itself is a big deal. It's thousands of dollars, the cost of writing the MCAT. So what I created this last year was a free MCAT preparation course for students in the community of support who can demonstrate, who have the financial need for such a course. So we got some money from the Canadian Medical Association. I think there were 31 students who were part of this, and it looks as though their scores went up dramatically after they participated. And the tutors and the mentors here were medical students. So I think there were 60 medical students who acted as tutors for this. But stuff like, and we would love to grow this even more, because this is the kind of thing that makes a difference. So other things that we're working on, and so there's a group called Bright, and so this is graduate students. So this is again where we have had a vacuum so far, and we need to do more to provide mentorship for underrepresented minority graduate students. And so this group formed. It's called Bright, so Black Researchers Initiative to Empower, and we're working with them to create more opportunities for mentorship and networking. So we also have a program. So this program existed before, but we've just kind of reimagined it and revamped it. It's called the Diversity Mentorship Program. So far it's been for medical students. And so medical students who belong to different equity-seeking groups can ask for mentors, and we put a call out to faculty as well. And we try to pair, and when we ask the medical students, what are you looking for? And we try to pair them up. So we had our launch, I think, 2 weeks ago, and it was fantastic. So this kind of a program really works as well. And so far we've been focusing on medical students, but we know that we need to do much more in this area too. And our intention is to focus next on the post-MD trainees, and then of course to expand it to the scientific trainees as well, so the graduate students and postdocs. And then I alluded to it before, so I won't go get back into it, but we have a few programs that we have created to try to break down some of the barriers that impair students that prevent them from applying to medical school here. And so the Indigenous Student Application Program and the Black Student Application Program. And as I said, we've intentionally modeled them both after the MP-PhD program. Intentionally, we have not changed the academic criteria required. All right, and so this is just another paper I just threw in. So this was published in Academic Medicine this year, and it's called Gateways to the Laboratory. So how an MD-PhD program increased the number of minority physician scientists. So this it was a tri-institutional effort. So this was Weill Cornell, Rockefeller, and Sloan Kettering, and they created an MD-PhD pipeline program for underrepresented minority students. So it was a summer research program that provided opportunities for clinical shadowing, career development workshops, and extensive multi-tiered mentoring. So mentoring. And what they found is that of their 245 alumni, 74% were pursuing or had completed MDs, PhDs, or MD-PhDs. 88% had advanced degrees, and 17% had MD-PhDs. So that's amazing. Like, that's a success story. So if we could model that and do something similar here, I think the sky would be the limit. All right, and then just sort of to get back to some of our other strategic priorities. So again, on the theme of recruitment, retention, promotion, and leadership opportunities. So we've also recognized that individuals, that some groups have asked us for workshops and networking opportunities. So we held a faculty workshop for Indigenous faculty last year. And then last year, we had an academic promotion session for women within the Faculty of Medicine. So, the clinical faculty as well as the scientific faculty. And we had leaders. So we had the new head of the Decanal Promotions Committee, so Mary Jane Esplin, speak to to people about what the process is. And traditionally, the focus has been very much on sort of number of publications, all the usual stuff. But creative professional activity is really important. And one of the other things that's being looked at in the faculty is how do we value our clinical teachers and how do we reward all of that stuff like teaching and mentoring that women do disproportionately more of than men, but that goes sort of formally unrecognized. So how do we do that better? And that's an active focus of what's happening in the Faculty of Medicine. I think at the end of November, in conjunction with the Black Physicians Association of Ontario, we have, there will be a Black faculty academic appointment and an academic promotion workshop. And then we are trying to wrap our heads around, because the students, this has been very student-driven so far, but how do we create more mentorship and networking opportunities for women in science? There have been, many efforts, in conjunction with Ryerson, et cetera, driven by the students in some of our graduate programs, but we need to do more in this area, and we're trying to think about how do we do that better. So Sharon Strauss, who I mentioned earlier, has been thinking about would it be possible to implement, or how do we start thinking about implementing something like the Athena Swan program here in Canada. Sorry. And what the Athena Swan program is, for those who don't know it, this is a UK-based program which is designed to provide mentorship and support for women in science, so in STEM fields, at transition points throughout their careers. And so provide them with funding, mentorship, and support to allow them, recognizing that it is a leaky pipeline and people come in and out of the pipeline, and we need to do more to mentor them. And very importantly, this is tied to funding. And so for institutions to be eligible for federal or national funding, they need at different levels, so gold or whatever, I don't even remember all the designations, but at different levels, they need to show what they're doing and what impact it's having on more recruitment and retention of women in STEM careers. And I think we talked about this last one before, so we're making this is so important, the representation. And so we are, trying to get the word out there and at least trying to walk the talk that it's very important that in any meetings that are organized, any conferences, it's really important that we make an intentional effort to have our speakers reflect our population, because it matters. The representation matters. And if young students and trainees in the audience can't see themselves in anybody who's speaking, then they don't think they can be it. And just, for the Canadians in the audience, so Andre Picard, who's one of our local journalists, I just saw him on Twitter yesterday saying that he declined an invitation to speak at a conference lately because it consisted of 10 men on the panel. So he calls them manels, and he refuses to join them. So, we need to do more to make sure that manels are a thing of the past. All right, so, and just another word about the Athena Swan program. So this is a study that was published in 2017, looking at advancing gender equality through the Athena Swan Charter for women in science. And what they found is that both women and men said that participation in Athena Swan had brought about important structural and cultural changes, including increased support for women's careers, greater appreciation of caring responsibilities, and efforts to challenge discrimination and bias. So many said that these positive changes would not have happened without the linkage of Athena Swan to government research funding. But it comes at a cost, and so other people thought that there were unintended consequences, and there's always that perception that there's positive discrimination that's happening. So one of the things that they raised as a concern, and this is why it matters that leaders walk the talk, is concern about the program design and implementation. And so the perception that the program has a really limited ability to address long-standing and entrenched power and pay imbalances, persisting lack of work-life balance in academic medicine. All right, and back to the leadership question, because it was brought up before. I'm just going to show you a couple of different things. So this was, again, put out by the AAMC, and so this was from February. This paper came out in February 2015. And it basically looked at women in leadership positions at US medical schools. So they looked in this period here, so they looked at 2003 to 4, and then at 2013, so 10 years later, a full decade later. And then what they found is that if you looked at division heads, 16% of them were women in this period here, and then 10 years later, we were only up to 24%. Vice department chairs, 19%, and then 24%. Department chairs, 10%, and then 15%. Assistant dean positions were pretty good, but more on that in a second. Associate dean positions, 30% were women, and then 39%. And then if you look at medical school deans, 10% were women, and then 16%. And then they did a deep dive looking at different departments, and you can see that it's all over the place in terms of department chairs who were women. And so depending, it ranges from 0% in orthopedic surgery up higher. But I'm going to pick on pediatrics. So in our department, so in pediatrics, so this is across the US, we know that there are lots of women. And in fact, 53% of the total faculty are women, but only 20% of pediatric department chairs were women. And then this paper came out very recently. In fact, I think it may be out now, but I saw it at first when it was published online. And this is by Nina Shore, who is a member of ANSPDEC and the chair of pediatrics at the University of Rochester. And it's called the Decanal Divide. So women in decanal roles at US medical schools. So this is the percentage of women. And again, if you look at dean positions, so it's pretty low. It's like 19% or whatever. And then if you look at vice dean and senior associate dean positions, it's less than 50%. Associate deans as well, and then assistant deans is just above 50%. But very interestingly, that when you looked at the kind of dean positions, like the types of positions that there were, so this again is the percentage women on the y-axis. So if you looked at the types of positions that there were, so the women were much more likely to hold these leadership positions in roles that pertain to education, mentoring, and image making, and so the institutional public image. But when it came to sort of the hardcore things like corporate strategy, corporate decision making, research, clinical, and then the overall leadership, so anything addressing corporate strategy, policy, finance, government relations, those positions were overwhelmingly held by men. All right, and so just sort of wrapping up, so the third thing that we're thinking about is how do we enhance our curriculum? And so I think some of the changes that have been made and are being made have focused on the MD program so far. And in the MD program, faculty leads have been appointed, so there's an LGBTQ2S faculty lead, and leads in Indigenous health, so that's Lisa Richardson and Jason Pennington. And then just this year, a Black health theme lead was appointed, so that's Anya Norum, who is a family physician and health policy, and a member of the Dalla Lana School of Public Health. So a lot of the initiatives are also driven by the medical students. They see very clearly what our deficiencies are, and this group called Social Justice and Medical Education has been a big part of trying to change some of the curriculum and change what we're doing there. And the overall concept is what we want to do is not make it, okay, now we're talking about diversity and inclusion, but the rest of the time we're talking about real stuff, but trying to make sure that we're weaving concepts of equity, power and privilege, inclusivity, and anti-oppression throughout the entire curriculum. So even though the focus has been on the MD curriculum, again, this needs to move through to everybody within our faculty. And the next step is within the post-MD curriculum. And some departments are doing this already, so such as the Department of Medicine. And I think we are trying to organize some things in the Department of Pediatrics, but it needs to move well beyond that. We talked, I think I'm almost done, but we talked about bias, so implicit or unconscious bias. This is so important, and we are making, and we're trying to address this head on. So this needs to be thought about for all admissions committees, all search committees, and all hiring committees. And our approach so far in the Faculty of Medicine has been that whenever a search committee, whenever a search committee is struck now, excuse me, there's education and discussion with the committee about what this is about unconscious bias. So that's in the form of videos, some in-person workshops, and some written material that we're putting together. So this is for search committees, and it's now being implemented for the MD admissions committee. And the goal is to try to develop something that can be used by other departments as well. And many departments are already doing this, but not uniformly across the entire faculty. So that needs to be a focus. And then, just getting back to this concept of allyship, and we've very much tried to focus on this idea of allyship. And so just, how do we respect one another, and how do we support one another, and stand up for one another and speak up for one another. And so, and we're trying to do this in different ways. So through the open forum, the one that we had and the one that's coming up. And for those of you who read, so a very important part of the Faculty of Medicine communication strategy, so the med email that goes out to everybody in the whole Faculty of Medicine, to alumni, etc. If you notice that several of the dean's messages in the last year have been around this topic and around issues of equity, diversity, inclusion, and allyship. Workshops, we're trying to figure out different sharing stories, because there's nothing as powerful as a story. It's really easy to think that this stuff doesn't happen until you hear from somebody that you know and you work with that this stuff happens all the time. So sharing stories in a safe way. And then we're trying to, in terms of education for faculty and for leaders, we are putting together some workshops for leaders. And we're trying to, we're just at the beginning stage now, but we want to create some online resources like modules for faculty, for busy faculty members, so that they can start thinking about allyship and what does it mean. All right, so just to wrap up then, so again, it's all about not reinventing the wheel, and I'm just going to finish with some lessons in my reading from the business world. So this is from a Forbes Insight piece called Fostering Innovation Through a Diverse Workforce. So they interviewed 321 executives who worked with companies, like big companies, with an annual revenue of more than 500 million US. And what the key messages were that diversity is a key driver of innovation, and it's critical for success on a global scale if you want to be competitive. You need a diverse and inclusive workforce. It's crucial for attracting and retaining top talent. And nearly all the respondents reported that their companies had diversity strategies in place, but interestingly, and probably rightly so, not all the plans were the same. And there were differences depending on the cultural or the regional differences. So just as an example, I mean, the strategy that we're adopting and the intentionality, I guess, in Toronto might look very different in Winnipeg or Saskatchewan, where the population might be slightly different. And so each school, even though I think the same principles apply, each school probably wants to think about how do they best serve the needs of their community and their population. So the other really important thing, and I say this all the time, is that the responsibility for success of these different companies' diversity and inclusion efforts really lies with the senior management. And for 7 out of 10 of them, the buck stops with the people with the C-level jobs and the board of directors. And I say this all the time, that it's the leadership that needs to walk the talk, because that's the only way that you can start to change the culture. And there needs to be accountability. So, when you look at, and just as sort of as the last slide, when you look at the characteristics of successful diversification programs in academic medicine, so a few things are true. So it's not one approach or one intervention that makes a difference. It's a multi-pronged approach that helps. And even though we're all important, especially me, we're all impatient and we want to see things change right away. It takes a really, really, really long time to start to see demographic changes. So in academic medical institutions that do this well, it might take 15 years to start to see demographic changes. But you can see the cultural shift happen much earlier, and I think that is what we need to focus on. And just going back to, in the Faculty of Medicine, so, when you look at our strategic academic plan for the last 5 years, so we're due to update it actually, so the promotion of social justice, equity, diversity, and professionalism. So this is something that we strive for. But, again, we remind ourselves all the time that equality and equity are not the same thing. So equality is really about sameness. It's about trying to make sure that we promote fairness and justice by giving the same thing to everybody. But it only works if everybody starts off in the same place, right? Equity is more about fairness, and this is what we should be striving for, equity and not equality. So it's about making sure that people get access to the same opportunities, even if they start off in different places. So with that, I'm going to end, and thank you very much for your attention.
Great, thank you, Lisa. That was really, I think, thought-provoking, and it's really great to see the efforts that are going on at U of T to try to address this issue. So we have about 5 minutes for questions. If people want to type in some questions or email them to Linda. And I guess one of the things that I might just ask you, Lisa, in my experience, having people look at the videos and things like that, there's a bit of a sentiment of, we have to do this, but we really don't care. And it's sort of a joke that we have to do this. And they're not really, actively feeling like this is important. It's a bit of a, oh, ha, ha, ha. Those unconscious bias videos, yeah, I'm going to do it. So how do we change that culture.
For sure, absolutely, and that's true. And so, we're thinking a lot about how to do this effectively. So if I can look at, so going back to academic institutions that do this well, so it never works when there's that sort of there's that diversity person, that token person who's talking about diversity and inclusion. So when it works the best, it's when when it's senior members of the faculty who are part of these committees, who are the ones who are the proponents and who are the champions of equity and inclusion and diversity. So, ideally it should be the chairs of the committees, but it works best when you have champions who are throughout the faculty who occupy very senior leadership positions. So we're thinking about how do we find those people and how do we train them and work with them to develop that. That's the model that works the best. We're not there yet by a long shot, but that's where we want to get. But that's a good point.
And I guess another question. So, obviously your focus has been on the medical school, and what can we learn for other clinician scientists, researchers, other programs? How do we? Is it a similar type of techniques that you think would be useful, or?
I think it depends. So, I didn't show you some of the data, but when we were collecting data early on, some of the data, so it's not just for the medical students, but it's also for the students in the rehabilitation sciences, and the same challenges were there with respect to diversity and inclusion. So it may look different with respect to gender maybe in different programs, but the racial differences are still there as well. So, but I think we need the data, and so that's why our focus has been so far on the medical learners, but everybody needs to do this because I think it's really important to understand the context with respect to scientific folks as well as people in other health professions.
Right. And I guess I guess I would say it's sort of the best of times and the worst of times, and the reason that I say that is because I think out in the media now there's a lot of concern, and this is being addressed, and the data is getting out there, but yet I feel also it's the worst of times because I think the political environment, maybe not so much in Canada, but perhaps in the US, it seems to be making this a really difficult issue, and maybe that issues of racism and all of that seems to be escalating almost. And so, it's sort of an interesting time to be trying to deal with this, because I think the political landscape on the one hand is favoring it, but on the other hand it's kind of squashing it down as well.
Absolutely, I completely agree. And yes, I think clearly what's happening south of the border is concerning to everybody, but we're not immune here, and we have lots of instances, in our own country where we see this type of behavior. And I think, things that might not have been politically correct to open, we're looking at what's happening in anyway, I won't go on, but in different parts of the country around different issues, and things that maybe wouldn't have been said openly before, people sort of feel like it's okay to say these things openly now. It's not just in North America, but around the world. So, and so that's why we also, we have paid a lot of attention to making sure that people within our community, it's not just, who's here, but we need to make sure that we're supporting them as well, because a lot of people are distressed, within I'll just take our faculty of medicine community. So, around all of the things that happened with the travel ban and all of that when it was first being talked about, there's distress among, people within our community, and we need to be mindful of that and make sure that we're there in solidarity with them and to provide support. So I agree with you completely. It's the best of times, we're talking about it, but it's the worst of times too.
Okay, well, I think there's no additional questions. I'd just like to really thank Lisa for this really interesting and important discussion that we've had. I'd like to thank everybody who sent in questions for participating. And I just want to remind everybody that we are going to follow up with Imogen Co. with a Twitter chat on Tuesday, November 14th from 9 to 10 p.m. Eastern Standard Time, addressing this topic. The other thing I'll just ask is for everybody to complete the evaluation survey. And there's a link in your promo email and flyer to the Red Cap survey, just to make sure that you fill out so that we can get evaluations. We always want to try to improve. So thank you to everybody for joining, and thank you again to Lisa.
Oh, well, thank you for the opportunity, and thank you for your attention and for your great questions. Thank you.